Good evening, doctor.
Hi, how are you today?
Surviving yourself?
I'm pretty good. So today the patient is here and their chief complaint is that his tooth hurts. He's scheduled for extractions on numbers 3, 20, and 30. An intraalveolar nerve block and long buccal nerve block will be needed for numbers 20 and 30. And a greater palatine nerve block and buccal and palatal infiltrations will be needed for number 3. I would classify our patient as ASA class 2 because he has hypertension, which is a systemic condition that is well controlled. Our patient is on 2 types of medications.
Doctor, I'm taking Lasix and lisinopril to help with my high blood pressure.
Do you take your medications regularly?
Oh yes, regularly. Every day, twice a day.
Are there any new medications that you're taking?
No.
And are there any other changes in your medical history that I should be
No,
aware
no
of?
changes.
Thanks.
So for the next step, we want to take the patient's vital signs. The most important one of them being the blood pressure. So what we're going to do, we're going to put this cuff on the patient's biceps. We are interested in the anatomical landmark called antecubital fossa. And once the cuff inflates, it will measure the pressure in the brachial artery. So please extend your hand. And we got our readings. The patient's systolic pressure is 130, diastolic is 90, the pulse is 70, and the heart rate is 12. According to our guidance, we can treat this patient at our facility here, and we do not need to move him to a hospital because his blood pressure is within normal limits, and it's also being controlled by medication.
So before we perform the procedure, we need the patient to sign the consent form. So possible risks would be discomfort, swelling, and infection. The patient might also develop nausea and vomiting, but those are very rare. And alternative to local anesthesia, the patient can also choose to do a general anesthesia, which puts the patient to sleep.
What do I have to worry about with that?
So compared to local anesthesia, general anesthesia has a more complex complications, which are more life-threatening. And you also have to make sure the patient did not eat anything 8 hours before the procedure and have someone drive her home. So you also have to make sure the patient take the same medication as usual. In this case, it's hypertension, the medication for hypertension.
Okay, I'll sign.
So for the procedure, I'll first apply the topical anesthesia, and then I would do 3 different injections for the 3 different teeth. So do you have any anxiety for today's procedure?
Yeah, I'm a little nervous.
So on a scale 1 to 10, how would you rate your anxiety?
Maybe a 4.
Okay, I would use topical anesthesia to lessen your discomfort, and I will also make sure to check your anxiety throughout the whole procedure.
Okay, that makes me feel better, thank you. To put the syringe together, you put the carpule in and make sure that the plunger is on this end, and then you put the needle into this side.
Let's go.
After the syringe is set up, you tap on the back to make sure the harpoon is engaged into the rubber stopper, and then you can take the cap off and you'll just check for flow by placing a few drops. So that our patient is in a lying down position, and for the injection for number 30 we have to do an intra-alveolar nerve block and a long buccal nerve block. The anatomical landmarks for that are the coronoid notch, which you can find with your thumb here, And then also the pterygomandibular raphe, which is here. And you're aiming for the pterygotemporal depression, which is in between the two. And then to make sure that you're at the right angle, you use the contralateral premolar, and that's where we place the barrel of the syringe. And you want to be about you use the height of the posterior molars. And when you're going in, you put the syringe about 3/4 of the way in. So with this injection, we're aiming for the intra-alveolar nerve, which is the incisive, mental, and then also the lingual nerve can be anesthetized. Is the long buccal nerve block. And that's what you want to do after the intra-alveolar nerve block. The landmarks are the most buccal side of the molars, and you'll inject a few drops here and then pull back slightly in order to get that buccal tissue for the long buccal nerve block. What you'll do before the injection is you'll use this lolly cane and you'll use those same anatomical landmarks, then you'll place it there and you'll leave the Q-tip in their mouth for a few minutes, and then that will just anesthetize the tissues a little bit for them to make them more comfortable. To actually do the injection, we will find those landmarks again with the coronoid notch and the raphe, and I will use the contralateral premolar with the barrel of the syringe, and I'll go in until I hit bone, and once I hit bone I pull back a little bit, and then I pull back on the end of the syringe to aspirate. If there's any blood, you take it out. If not, then you can proceed and then you inject the carpule here. For the long buccal, you do the same until you reach bony contact, and then you place a few drops and then you pull back. Do you feel this at all on your leg? And if they don't, that's how you know that that tooth is anesthetized. This is to take apart the syringe, and you do that by either first you do the scoop technique, or you can use a hemostat to put the plastic cap back onto the needle, and then you can take out the needle, and you put that into the sharps container, which is over there, and then you can also put the carpule into the sharps container.
So before us, we have the armamentarium for anesthetic delivery, which consists of this syringe, the long 27 gauge needle, which is capped, and the carpule. So what we're gonna do, first we're gonna take the syringe, we will pull the harpoon back, then we will put the carpule in like this. After that, we will take the capped long needle and insert it like this. At this point, we will tap on the harpoon to engage the syringe, and then we should be able to remove the plastic cap. At this point, we want to make sure that we have the flow, and we press ever so slightly until we see the liquid coming out. At this point, we are ready to deliver our anesthetic. So before we go in with the needle, we want to apply some topical anesthetic in these sites of injection. So in our case, that's going to be onto the buccal mucosa as well as into the palatine mucosa around tooth number 3. So for maxillary buccal infiltration on tooth number 3, what we are going to do, we are going to come buccal the tooth number 3, and we will be going up like this, pretty much parallel to the axis of the tooth. We will go up until we hit apical 1/3 of the tooth, at which point we will tilt the needle to 60 degrees, push a little more, aspirate to make sure we do not hit a blood vessel, and at that point we can inject 1/3 of the carpule. And that is the maxillary buccal infiltration, which targets the posterior superior alveolar nerve. So now, to take care of the other half of the tooth, we will come from the lingual side and deliver a greater palatine nerve block. So the landmark that we are looking for is called the greater palatine foramen, and it's located lingual to the third molar, right there. However, we don't really see it, so we will be using the first molar as the landmark, and we will come in distal to it. So the needle will be pointed at a 45-degree direction, and we will go just distal to the first molar. We will push the needle in, aspirate to make sure we didn't hit a blood vessel, and then we will deliver 1/3 of the carpule. To make sure that the patient is numb, for maxillary teeth we cannot tap the lip like we could do with the inferior alveolar nerve block. So what we would have to do, please open up, we would have to check the soft tissue on the palatal side and on the buccal side to make sure that the respective blocks worked. Alternatively, we could also use the endo eyes on the tooth to make sure that it is not sensitive. Alright, so now that we have delivered our anesthetic, we have a live needle here, so we need to safely dispose of it. So what we could do, we could use a scoop technique and put the needle in the cup, like this. Alternatively, we could also use a hemostat to hold the plastic cup. So once the needle is set, we would remove the capped needle like this, and we would dispose of it into the sharps container, which is over there. And that is also the same place where the used carpule would go.
To assemble the syringe, first we pull back the ring of the syringe, and then we insert the carpule into the syringe with the rubber end facing the harpoon, and then we insert the cap needle, a long needle, into the syringe, and then I give it a little tap on the back to engage the harpoon. After that, I remove the plastic cap of the needle and check the flow. I will apply the topical anesthesia at the pterygotemporal temporal depression before I do the actual injection. So first, you find the corona notch by propelling, which is right here. And then you find the pterygoid mandibular raphe, which is right here. And then between that, you have the pterygoid temporal depression, and that's what we are targeting. So you place your syringe at the contralateral premolar at the height of the molar, right? At the height of the molar. So the landmark for long buccal injection is just the mucosa of the buccal aspect of the teeth. After the needle is in contact with the bone, I draw back a little bit, and then aspirate to make sure there's no blood in the carpule. After I make sure there's no blood in the carpule, I inject the anesthesia. After the needle is in contact with the bone, I draw back a little bit, aspirate to make sure there's no blood in the carpule, and then I inject the anesthesia. So to make sure the patient is anesthetized, you poke this, the center of the lower lip, and then ask her, do you feel anything?
No.
So to disassemble the syringe, I use the scoop technique to scoop the needle into the plastic cap. After that, I take off the needle and put it into the wasted container. And then I pull back the ring of the syringe and take out the carbo and then put it into the waste.